This is the Emergency Medical Minute, sponsored by CarePoint and HCA Health One.
Good morning, everyone. Today I want to talk about Tramadol, or as some people refer to it as Trama-don't. So we're going to start with a little pharmacology lesson here this morning. So Tramadol is not a medication we see a ton, but it is something that sometimes people request as a refill or they request as a pain medication. So I think as healthcare providers, it's important for us to be well versed in it. So start with a little bit of the background. So it was developed in Germany in 1970. Or 62, didn't come on the market there till 77, and then was approved in the US in 1995 solely for pain management. I want to talk about the mechanism because it's actually pretty interesting. So there's kind of two, if not three, mechanisms of Tramadol. Number one, despite it being a pain medication, the Tramadol molecule itself acts at the mu-opioid receptor at like 1/6000th the strength of morphine. So 6,000 times weaker than morphine. So as its molecule itself is a pretty poor pain medication. It also, number two, acts to reuptake norepinephrine and serotonin. So similar to our SSRIs for depression, this is what we refer to as SNRIs. So this is like Effexor or Cymbalta. And number three is that the molecule is broken down into a metabolite, most specifically this one called O-desmethyltramadol, ODT. And this is where you get your mu-opioid effect. So this metabolite acts at our opioid receptors 300 times stronger than the actual original Tramadol molecule. So it does act at the opioid receptors. The catch here is that in our livers, we have these enzymes called these cytochrome C450. There's one specifically for Tramadol called the cytochrome CYP2D6. Not really important, but for completeness sake. And this enzyme breaks down the Tramadol molecule into this metabolite. The problem is there's really no rhyme or reason to knowing how much any individual is going to break down. So there are some patients, about up to 10% of the population, that are just poor metabolizers. So they really don't break it down at all. So you give them Tramadol and they end up with almost 100% of an antidepressant and they get no pain relief. Then there's this middle group where they kind of break it down like 50-50 and they get a mix of pain medication and SNRI. And then there's a group of ultra-rapid metabolizers. So people that are, Middle East and North Africa, almost 30% of the population there are these super metabolizers. And they break down almost all of it to a pain medication. So they're these super metabolizers that get a really high dose of pain medications. And there's no way to know. So basically, if you're giving Tramadol, you're rolling the dice saying we're either going to give you an antidepressant, a pain medication, a mix of both, all one or all the other, and we don't know. So that's why it's a pretty poor medication. And if that's not enough, I want to talk about some of the side effects real quick. So Tramadol is disproportionately associated with first-time seizures and seizure risk, even at very moderate doses. Serotonin syndrome, so although weak at triggering it, if you take it in combination with SSRIs or SNRIs, or you don't really understand the mechanism, you can precipitate a serotonin syndrome. And then the drug interactions, this one I think is super interesting and important. So that same cytochrome system, there's a lot of meds out there that actually inhibit that system. So if you have a patient who was on, let's say, bupropion for smoking cessation or paroxetine for depression, terbinafine for a nail infection, or celecoxib for ongoing pain, these all inhibit that cytochrome system. Let's say you have a person on Tramadol for pain, it was working well for them, and you start them on one of these medications, you're actually going to send them into opiate withdrawal because you've inhibited that mechanism that they were relying on to get their opioid receptors. And also, because of its partial opioid action, Tramadol is responsible for a lot of physical dependence and abuse. So worldwide, this medication has surged in the last 20 or 30 years. It's cheap, it's accessible, it's often perceived as a safe opioid, but this, widespread use has led to quite a few deaths, usually in combination with other substances. And so the bottom line is it's, in my opinion, a pretty dirty medication, pretty unpredictable kinetics, and a litany of dangerous toxicities, and there's just so much more better, cleaner medications out there that I personally try to avoid it as much as I can. That's all.
This has been the Emergency Medical Minute. Thank you to our sponsors CarePoint and HCA Health One. Support from them and listeners like you helps us to continue providing free medical education to the masses. If you found this episode valuable, consider supporting our work and check out the link in our show notes.